So that's when we led on to stage 2, that's Going for Gold, which is a distance learning program which really embeds it much more deeply. That was in 2009, and advanced care planning is integrated as part of that. So that's going around in different primary care trusts at the moment. I think we've had about 200, 300 practices doing it, and it's a practice-based distance learning program. So next slide, the care homes, or the ACF, 2,000 trained and structured program with the curriculum. And this is much more tight now than the primary care one was. Over the first 3 years, we tightened it up so that we put accreditation standards in and we teach against those standards. And it's much more specific now. And then findings go to an independent panel. In fact, tomorrow we're having our second award ceremony. We had one as part of the ACPEL conference a few weeks ago, but lots of people couldn't get to that. So we're having another 40 or 50 care homes receiving awards tomorrow. So, and that's the Quality Hallmark Award we give them. So the next slide, the 20 standards. This is in the care homes work, ACS. The key 4 things are the ones in red: GP collaboration, advanced care planning, reduced hospitalisation, and care in the final days. But it does cover a lot of things, and I won't go into this in detail, of course, but it's much more structured now because we set out what we're trying to teach, and then we illustrate it and model it, and then they have to go back and show that they're doing it, and then come back because so there has to be some kind of consistency of care. Now that we've got about 250, 300 accredited care homes, and lots more coming through the process now. And a big focus, the next slide, big focus, I'll skip through this, about reducing avoidable hospitalisation, because we have such a big focus on that. So all the different factors that I've just listed, some of them there, that contribute to reducing hospitalisation. It isn't just one thing, it's lots of different things. And the next slide shows the halving of hospital deaths. We did some studies. This is a while ago now, because we're on phase 7, going out to phase 8, but this is phases 4 to 6, and showing the decreased hospitalisation and hospital deaths. So decreases crisis admissions and decreased hospital deaths. We find that some people in care homes still think that hospital is the best place for some patients to go, and maybe it still is, and I don't quite know what it's like in New Zealand, but for us it was too many people. It was a default position, sending them off to hospital, and too many, especially elderly people, were ending up there, and there's been lots of focus on reducing that. So, and the cost effectiveness of reducing it. So estimated 30 to 40,000 per care home per year, and that multiplies up. And there are lots of other studies showing the cost effectiveness of reducing hospitalisation. So next slide, I just mentioned about the hospitals, although I mentioned it before, and it might be of interest, but it's a really important part of care to bring the very bare bones of GSF. It's much more basic when we do the hospital work, but the bare bones of it to hospital wards. We find hospitals, places of very rapid turnover of staff. They haven't got any time. They can't sit and talk to patients very much. And but just the same kind of thinking, so that the cross-boundary care, patients coming into hospital and patients going out from hospital, really benefit, and you're talking the same language. Otherwise, you've done all this work in the community, and they come in, and it's just like the Bermuda Triangle. Everything gets lost as they come into hospital. And we also find that more are using the Liverpool Care Pathway in the hospital if they've planned earlier, and there's earlier coding. So next slide was domiciliary care, and that's when we use the head, hands, heart. I don't think I'll go into that one, so you can jump through that one, Joe. So then the integrated cross-boundary care is beginning to work, and I was going to mention this and talk to Simon about it, but it's really exciting that with home and care home, or ACS, and acute hospitals being the main places where people die, still 60% of people die in hospitals, but if you're starting to put things together, you get a sort of integrated, coordinated care. It's beginning to work, and we're certainly dedicating a lot of next year to doing some pilots. We had another area wanting to be part of this pilot next year. So trying to look at how we can join things up and put patients at the centre. So I'll come back to that. Are you doing all right so far? Not much longer?
Audience is still awake?
Yeah, I'm fine. I'm an evening person. So. And international partnerships, it's really lovely that we've got our first regional or international centre working in Tasmania, so not too far from you, with Robin Brogan doing some work there in 3 care homes or ACS, and then also 3 more later in the year. And lots of bits of work going on in Australia, and I put New Zealand there, but other bits as well. So it's very interesting how the same principles can be taken and adapted by different countries and different structures. So I'll come back to that at the end, maybe. So next slide, just although it's a busy slide, that just gives a quick overall impression of the different tools and resources that we use related to those things of identify, assess, plan. And just to say that there are a number of different tools. If it just goes to the next slide. We did find when we did this work with primary care, with GPs initially, the key bottlenecks that they found, and actually it's fairly consistent in other areas, were identifying the right patients, especially those with non-cancer, having the difficult conversations with patients and families, advanced care planning discussions, what they call crucial conversations, and thirdly, effective team meetings and pre-planning and coordination of care. And those were the three things that were constantly going wrong. Others as well, but they were the three areas in particular, with communication really running all the way through. So on the next step, so we've boiled GSF down to those three steps really, identifying, assessing and planning, and all the way through in everything we do, we come back to that identify, assess, plan, and that's why that toolkit is a whole lot of tools and resources about identify, assess, plan. So next stage, advanced care planning is part of the assess. So next slide, just looking at the identify. So if we're looking at 1% of the population die per year, why aren't we picking them up? And there are lots of reasons why we aren't. And we use, again, Joanne Lynn's surprise question, although we apply it to, would you be surprised if a person was to die in the next days, weeks, months, years? And then some patients have a particular preference and want to stop treatment, and they make a decision like renal dialysis or whatever. And then thirdly, clinical indicators. So the prognostic indicator guidance, which is just out for further review, it will be done in a couple of weeks, I hope, working with the Royal College GP. So we update it every couple of years. And it's a guide to which patients might be thought of to be in the final year or so of life. But it's a very loose, it's very unscientific, but it just is helping people to understand that there are ways of predicting these things. And then we colour code, which we got at the bottom there. Then advanced care planning discussions, we had a whole conference on that, and I know you're doing some more work. You do work on it, and you're talking about it later on in the afternoon, aren't you? So I won't dwell on that. But we use one document called Thinking Ahead, but there are lots of different documents. It's the process of the discussion with the patient and the family that's the important thing, and then transmitting and communicating that information to others. So the next bit, planning particularly across boundary care, across different sectors, and then also planning care in the final days so that people live and die where they choose, and of course using LCP. We've also, for some, got what we call the minimum protocol, which, because some care homes and practices said, we're never going to do LCP, so we said, well, you can't do nothing, you've got to do something, and we do recommend doing what we call the minimum protocol with John Ellershaw's agreement, and then from then they move on to LCP when the time's right. So at least they're doing something which is a bit like a checklist for dying patients. And then I also mentioned the 7 Cs, because that's how we used to do it several years ago. It was good, but most people said we haven't got time for 7 things. We've just got to have 3, identify, assess, plan. So we fitted these 7 Cs into other areas. But basically we chunked it up into particular tasks, particular things to do that we thought would lead to a gold standard of care. So next slide. So just the final bit of what we try and do is look at measures and metrics, and we try and break it down into those 3 areas again, which are linked to our 3 goals: the qualitative, the coordination, and patient outcomes, reducing hospitalization. And one of the interesting things is that people's experience of care and quality of care is very intangible, very difficult to put your finger on, but a lot of people feel greater awareness, greater confidence, which is really important, even though you can't always measure it. We do try and measure it with staff surveys and confidence levels and competence assessments and things, but sometimes there's a lot that's fairly unmeasurable in there, which is just lovely to see, a little bit of magic that happens when you really tap into the reasons that people came into the jobs in the first place. But then practical structure process outcomes and structure process patterns, and then better organisation documentation. And then thirdly, we do measure hospital admissions, crisis admissions, length of stay. But basically in patient outcome, we're also looking at the kind of care delivered in line with patient and family preferences. So the kind of listening that should go on. It's very hard in this whole world to measure outcomes, I'm sure you find as well. And you can put sort of proxy outcome measures and they can be wrong. But Anyway, so we look at outcome measures as well. So just, and then the third element, that third diagram with the metrics and measures, so I won't go into that, but we have lots of different measures, including the after-death analysis, which has been very helpful, that ADA audit, which is targeted to GSF in particular. So next slide, talking about bringing it all together now, gold patients. Patients like the phrase gold, and even though GSF, Gold Standards Framework, it was like one of those things. We got round the table and looked at, well, what would best care look like, and then a gold standard, and then what framework do we need to get there, and then it sort of stuck, and we couldn't change the name after a while. But patients like it, and now more and more they have these gold cards, and they're fighting over these gold cards. They like being called GSF or gold patients. It means best care. There are negatives. We can go into that at some stage. You know, there are difficult discussions to be had. Not everyone wants this, but there's something very important that goes on that people feel like VIPs. And yes, you can't beat death, but you can support people nearing the end of life. So next slide, if you just press again, putting patients right in the middle of care, that's the kind of thing that we're looking at, and the kind of thing I described earlier on with care homes, primary care, out of hours, but also community and hospices. We've got some hospices doing GSF now, and hospitals. So gradually bringing it all together in what we call, what has been called locality register, so a register of vulnerable patients, and then making sure everyone knows about them, and trying to make sure that their wishes are known and respected in lots of different settings. This is really complex, it's really hard, it's not easy, it's not working all the time, I'm not saying it is, but we can just see over the hill to where this is beginning to work. And when you hear the good stories of things starting to happen, for example, Simon, you heard about Karen Grove saying in the hospital work, they're identifying patients in the hospital that they call gold in the final year of life, and they're telling the GPs, and the GPs are then putting them on the register and discussing them more and more actively caring for them. So it's beginning to work. Then I've put next about the supported cascade. That's how we did it, and that's how we've done most of these. We've managed to do national cascades across all the 4 nations, but it's through the national team supporting local facilitators with local coordinators in project, just as you do with LCP and with other kind of cascades. I just jumped through those next bits.